Dysphagia and feeding difficulties. Case. Dear Dr. Mrs. Deborah Finch, aged 67 years. I would be grateful for your assessment of this woman who has noticed increasing difficulty in swallowing over the last 6 weeks. She has a long history of reflux symptoms and uses ranitidine for this. She has also had a stroke in the past. She does not think she has lost any weight but is unsure about this. I am concerned about her symptoms and would value your opinion as to whether they are related to dysmotility or some other problem. Yours sincerely. Introduction. Dysphagia means difficulty swallowing and is an alarm symptom that should be investigated rapidly. It may be due to dysfunction in the mouth, pharynx, or esophagus, with the history usually identifying oral problems. Causes are listed in Table 2, but the obvious concern is that it might be due to carcinoma of the esophagus or gastric cardia, which should be the working diagnosis until proven otherwise. Pain on swallowing is known as Odynophagia, but although patients may describe this together with dysphagia, it is the latter that is the most concerning. NB. Although the patient will often indicate the apparent level of obstruction on the sternum, this correlates poorly with the actual site of blockage. History of the presenting problem. Related to difficulty in swallowing. Speed of onset. Rapidly progressive dysphagia is suggestive of a malignant stricture, whereas gradual onset of symptoms stretching back over 6 months or more is typical of a benign stricture. Problems with solids and/or fluids. Strictures, benign or malignant, usually cause dysphagia first for food, particularly bread and meat, and later for liquids. Dysphagia for liquids, more so than solids, often indicates a pharyngeal problem, e.g. stroke, motor neuron disease. Dysphagia for solids and liquids from the outset is typical of achalasia. Is there regurgitation? This may suggest holdup of food in the esophagus. Nasal regurgitation is associated with neurological causes of dysphagia. Pain on swallowing. This occurs in reflux esophagitis, achalasia, esophageal candidiasis, and herpetic esophagitis, and also with benign and malignant strictures. Other symptoms. Any mechanical blockage to the passage of food into the stomach will restrict calorie intake and result in weight loss. Severe and rapid weight loss tends to point to a malignant process. Is there a history of reflux acidity with an acid taste coming up into the mouth? Chronic acid reflux can lead to esophagitis with subsequent stricture formation, and patients with gastroesophageal reflux disease, GORD, can also develop dysmotility due to chronic acid damage. Epigastric pain may suggest peptic ulcer disease and reflux. Patients with some neurological diseases can develop dysphagia due to involvement of the upper third of the esophagus, striated muscle. Stroke with pseudobulbar palsy is the most common, but dysphagia can also be seen in motor neuron disease, multiple sclerosis, Parkinson's disease, and myasthenia gravis. Other relevant history. Drugs. NSAIDs, potassium salts, bisphosphonates, and tetracyclines have all been implicated as causes of esophagitis and esophageal stricture formation. Immunosuppressive medications, diabetes mellitus, chemotherapy, or HIV infection predispose to esophageal candidiasis, which may be asymptomatic or cause symptoms of heartburn and dysphagia. Past medical history. Radiation-induced esophagitis may occur weeks or months after irradiation treatment for malignancies, e.g. bronchial carcinoma. Are there any other serious medical comorbidities? These may limit the choice of investigation for a patient, e.g. endoscopy is more risky in the presence of significant cardiorespiratory disease. Social history. Alcohol excess and smoking are both risk factors for the development of esophageal cancer, as well as being aspects of lifestyle that could be usefully modified in patients with GORD. Plan for investigation and management. After explaining to the patient that under normal clinical circumstances you would examine her, you would plan as follows. Routine blood and radiological tests. Check FBC for evidence of iron deficiency or anemia. Electrolytes. Renal function may be impaired due to dehydration. Liver and bone function tests. Albumin, a marker of nutrition. Inflammatory markers. Hematinics. Plain CXR may show hiatus hernia or carcinoma of the lung leading to dysphagia by external compression. Investigation of the esophagus. NB. Investigation of dysphagia. Barium swallow, urgent. Endoscopy, biopsy and brushings to exclude malignancy if any stricture is identified. Manometry, consider if endoscopy or barium study negative to exclude achalasia. NB. No matter how likely the diagnosis of a benign stricture, a patient with dysphagia requires investigation with a barium swallow and endoscopy to rule out malignancy. Barium swallow. This is the most appropriate initial investigation when a patient describes high dysphagia. It allows the site of pathology to be identified and forewarns of pitfalls such as a pharyngeal pouch, Fig 2, which if unidentified increases the risk of perforation at endoscopy if vision becomes obscured as the endoscope passes through the cricopharyngeus muscle. If dysphagia is not severe or if a stricture has been previously diagnosed and located, Fig 3, then endoscopy may be the initial investigation. Endoscopy. Endoscopy allows characterization of the type and length of a stricture. Any stricture must be brushed and biopsied to exclude malignancy. Dilatation and / or stenting may be performed if a stricture is impassable and dysphagia severe. Manometry and pH studies. Esophageal manometry may be useful in diagnosing a motility disorder, e.g. esophageal spasm, if barium swallow and/or endoscopy are normal. It may also provide additional confirmatory evidence of achalasia, hypertensive lower esophageal sphincter that fails to relax on swallowing, following a suggestive barium study. pH studies can direct therapy in patients with reflux symptoms and can also identify patients with silent reflux. NB. Dysphagia without esophageal narrowing should lead to consideration of dysmotility, which can be identified and classified by manometry. Other tests. Other investigations may be required in some cases, e.g. serological tests in suspected scleroderma, electromyography, EMG, in suspected motor neuron disease. Management. Specific management will depend on the cause identified, Table 2. Patients with neurological causes may require artificial feeding, particularly if the condition is non-reversible and likely to deteriorate over time. Nasogastric tube feeding may be necessary in the short term, but for extended feeding programs the best option is percutaneous endoscopic gastrostomy.